be talking about behavioral management. And somebody who has a lot of experience with behavioral management.
I told you not to tell anyone.
Oops, sorry.
Dr. Veronica Shead joined the South Texas Veterans Healthcare System in July of 2012 as the clinical psychologist in geriatrics and palliative care. Prior to coming to South Texas, she worked at the Memphis VA Medical Center as a pain psychologist, where she also completed her fellowship training in medical health psychology with a focus on late life. Dr. Shead completed her internship training in clinical neuropsychology at the University of Arizona Medical Center and received her PhD from Washington University in St. Louis. While at Washington University, she was trained under a National Institute of Aging training grant and performed research on dementia and related disorders in combination with the Alzheimer's Disease Research Center, as well as completed projects on other areas of aging, including coping with chronic illness. Currently, she maintains research interest in late life issues, specifically palliative care, dementia assessment, treatment, and caregiving, as well as health disparities and their effects on minorities and older adults. Please help me welcome Dr. Shead.
So then that kind of frees me up a little bit, but I think I still need to stay up here in order to be seen by the video. Okay, all right. So I do like to move around a little bit, and it is the afternoon on a Friday, so I'll try to keep everybody awake this afternoon. Like they said, I'm Veronica Shead, and I am currently the psychologist in geriatrics and palliative care at the VA Medical Center here. Today we're going to talk about non-pharmacological ways to manage behavior, and especially behaviors associated with, in particular I should say, behaviors associated with dementia. I thought to start off I would go through a couple of things about initiatives that have taken place within the VA that deal specifically with dementia, and then go through a bit of evaluation and differential diagnosis. Then speak about agitation and behavioral problems, assessments, interventions, and then some specific veteran considerations, because I know that probably a large portion of this population deal with veterans. So the VA population is actually aging, even though we've had some of the more recent wars and have OEF and OIF veterans. We actually do have this aging of our general veteran population. So greater than 40 million Americans are over the age of 65, with 9 million of those individuals being veterans. 52% of veterans receiving care from the VA were receiving care from the VA health system in 2009 were greater than 65 years of age. This is also going to continue to increase because the baby boomer population and our Vietnam veterans are now aging into the older population. So this is why in the VA we're going to have to revamp the system. We kind of had a downward trend with the unfortunate loss of most of our World War II veterans, and now we're having an uptick of the baby boomer generation. As far as dementia prevalency, the lifetime incidence of developing dementia for adults over the age of 65 often exceeds 15%. And risk rises dramatically in the 7th and 8th decades, meaning that at that time, your risk at age 85 nearly increases to 50% for you having a risk of getting dementia of the Alzheimer's type. Now, while Alzheimer's dementia is the most well-known, other dementia subtypes constitute 25 to 30% of all cases. This type of research is always fluctuating because, as we know, most of the time we cannot truly diagnose or clarify which dementia diagnosis you have until autopsy. So we're learning more and more about what types of dementing disorders we're dealing with. But right now, the statistics in most of the research shows that dementia of the Alzheimer's type is the most prevalent. Dementia is often undiagnosed or underdiagnosed in primary care, and greater than 1 in 7 people with dementia of the Alzheimer's type actually live alone, and many without a known caregiver. That's going to be very important when we talk about some of these behavioral problems. Dementia of the Alzheimer's type is actually the 6th leading cause of death, with rates dramatically increasing over the last decade of life. So again, we see this trend, obviously, things that are associated with aging. Dementia is a disorder that is most definitely associated with an aging process. So as far as the VA, in 2006, VACO established a National Dementia Steering Committee. And this committee set forth by developing kind of these national work groups to address both clinical care, coordination of care, and administrative issues in order to deal with this issue of how are we going to treat having so many patients who are dealing with dementia. So they came up with 64 recommendations to enhance the VA's dementia care, and 39 of these are actually clinical recommendations. So what they came up with is that we needed to have these interdisciplinary vision and local dementia committees. And with that, they highlighted the need for provider education, so kind of things like what we're doing today, and preparation for the increase of veterans with dementia. The focus is on the importance of comprehensive dementia evaluation and treatment. So again, because this is a process that is a progressive process, we need to, as you saw, with the underdiagnosis of dementia in primary care, where we may see these patients first, we need to understand how to diagnose people, first of all, and then what are we going to do with them? Because right now we don't have a cure. So really, it comes into what type of care are we going to provide, how are we going to provide these services, and what services do we need? So that's why this whole evaluative process and treatment are actually all in a continuum when we're dealing with dementia patients. So, comprehensive dementia evaluation. I thought I'd go through this because one of the things is that this is what's going to actually give us a really good baseline in order to understand what is actually problematic behavior. So, first of all, you need a medical evaluation. So, a neurological and physical examination, a reversible dementia panel, a medication review, and then you need actually cognitive evaluation. So a clinical interview with collateral information, so that information from either a caregiver who lives with somebody or their closest friend or relative, course of functional cognitive behavioral decline, physical and behavior signs and symptoms, functional limitations and strength, and then neuropsychological testing, which obviously I think is useful. So again, we must understand what's going on in the first place. So thinking of potentially reversible causes with dementia. So depression for one. Depression can actually demonstrate itself in older adults as them having some cognitive problems. They can have lapses in memory that would look like they were having some type of dementing process. So you can kind of see those things. You can see slow processing speed. You can see people who actually have slowed motor function because of being depressed. So we see all of these things, and so we really want to make sure that we're able to tease apart whether this person is dealing with a depression or if they're actually dealing with a dementing disorder. One of the big signs is usually that the depression has kind of a shorter duration or a more abrupt onset. So all of a sudden they have these problems. Or oh, these problems come and then they stop. So those types of things show us that this are kind of some telltale signs that we might not be dealing with a dementing process so much. Delirium is also something that we really need to be aware of. It typically, again, has an abrupt onset as opposed to the insidious onset of most other dementias. It may co-occur with dementia. So one of the things is that when you have a patient with a dementia, they actually have a higher likelihood of having a delirium. So one thing that's very important in understanding behavioral problems is that sometimes what we're seeing is actually a delirium on top of a dementia. And so we must understand what the differences in that are, because usually a delirium is something that is due to some other type of problem. And so you'll see these fluctuating mental status and impairments in consciousness and attention. Those are kind of hallmarks of what a delirium would be, as opposed to somebody who is dealing with the dementing process. Also, it may be hyper or hypoactive, so you may see this kind of increase in problematic behaviors or changes, or you actually may see a person who becomes more somnolent and who is actually less active, which is actually still a behavior that we want to tend to. Often the problems have a predisposing or precipitating factors, and so we'll talk about a couple of those. So again, here are a list of some of the other things that could be going on with somebody. So intoxication, so we could talk about medicine or substances. So even thinking of alcohol, we still have patients who have polysubstance abuse who are in our older adult populations. So making sure we think of that. Comes to mind is that older adults don't necessarily tolerate some of the substances as well as some younger people. So I've had an 89-year-old who decided to try marijuana, ended up in the hospital and being tested for a dementing disorder. And we just talked about things about sex with older adults. The reason he did it was because his wife, who was 30 years his junior, was going through menopause. And they were trying to find ways to get her more in the mood. And one was to try marijuana. So again, that's where your clinical interview comes in and your background information, because their systems don't handle things in the same way. And so these may be why we're seeing different changes. Metabolic abnormalities, electrolytes, glucose, anemia, infections. Infections, that's a big one, especially when we're talking about delirium. So UTIs are a very likely culprit. Pneumonia, meningitis. Sometimes our older adults, their systems don't catch up with infection. So you might not see that elevation of their white blood cell count until after they even start showing some of the behavioral changes. So making sure that we're testing for some of these things beforehand. In our VA population, it is very, very important for us to rule out syphilis. We have a higher incidence of syphilis in our VA population, and so you want to make sure that we're doing what we'll go through again, which is a reversible dementia panel, to test for kind of all of these things, including the vitamin and nutritional deficiencies kind of listed at the bottom. CNS insult, so different types of, a lot of times a veteran may have fallen, you don't know, and then they come in, start having these problems. You want to make sure that gets tested. Toxins are another thing, and sensory impairment. Cannot tell you how many times we've had people referred for testing or referred for other problems, and really their main issue is that they have a hearing impairment. So they didn't hear you, or they have cataracts, and they didn't see what the doctor was giving them. They gave them the screeners, and they didn't realize that, number one, the patient couldn't hear them, so that's why they couldn't repeat the 3 words back to them. Or second of all, they couldn't see to actually draw, whether it was the clock or or another figure. They just didn't see it. And so sensory impairments are something that we really have to be aware of whenever we're assessing our veterans. And another big one is pain. Pain will actually cause a delirium in some of our older adults. So if they're having high pain levels, that can also cause those problems. So again, acute or chronic medical problems, and here's a list of a lot of different things that we have to look at when we're trying to consider consider potential reversible causes. So here's kind of what I would probably recommend is a very thorough reversible dementia panel. So the things you want to do in order to kind of rule out causes for cognitive issues that might be reversible, or causes for delirium that might be reversible even in a dementia patient. And so again, with neuroimaging, very important because you can actually see some of the changes that occur in the brain that might give us a little bit more information about what's going on. And medication issues. One of the biggest issues with older adults, and I know especially in our VA population, is polypharmacy. The fact that some of our veterans are on up to 30 different medications, one to treat the side effects of another, to treat this, to treat that. We are definitely dealing with situations where we're dealing with polypharmacy. These medications, although they might not put somebody under completely, they do have side effects, and they do have neurological side effects and can affect somebody's thinking. And so we need to be aware of that as well. Also, when we're dealing with outpatients, we need to recognize that patients have difficulties with managing their medications. So are they actually taking their medication the way that they're supposed to be taking it? That can lead to so many of those other problems that will lead to risks for cognitive issues and other behavioral problems. Another rule of thumb that we often tell patients is that any medication that can make you sleepy can impair your cognition and your fall risk. So if it doesn't impair your cognition, it can impair your fall risk. You fall, you have a subdural, then you have other problems. So we try to make everybody aware of all of these things. The common classes that we look for are opiates, benzos, anticholinergics, antibiotics, statins, anticonvulsants, and psychotropics. And I definitely have patients who are on all of those at one time. So again, how do we stay aware of those things, making sure you're up to date on knowing what's going on with Beer's criteria, for instance, and knowing which medications can cause issues for older adults. Neuropsychological evaluation very quickly goes through various domains of cognitive function. One thing is we often think of memory as the major problem. Sometimes we think of executive functioning problems as well. Those are kind of the two dominant areas that we talk about the most, especially in research more recently. But one thing that's very telling about a dementia is that actually it just needs to affect multiple domains of functioning. So if you have somebody who has language problems, for instance, there are primary progressive aphasics who will have primary language difficulties and can have some preservation in other areas of cognition. So we want to go through and make sure that we're assessing all different types of cognitive functioning and through all the domains. And it also gives us some help when we are dealing with issues of behaviors, because then we may know some areas where the person has a strength. Also, we talk about decline. One of the things is that sometimes some areas may be preserved. So, or we'll be able to see the decline once we see that other areas are being affected. So, differential diagnosis, and I'm going to go through this one really quickly, is that, again, we're dealing with primarily Alzheimer's disease, but there are a lot of different other types of dementia that we want to make sure we're aware of. There's a lot of information and research to talk about, for instance, Lewy bodies dementia, which that's kind of the thought process is that there may be increasing in numbers of that type of dementia. One thing that we oftentimes see in the VA, especially with our increased incidence of hypertension and diabetes, we actually probably see more mixed type or vascular dementia in our population than most others because of all the vascular risk factors. So a lot of times we see probably less Alzheimer's than we do vascular dementia in our population. And you see more, and our population is also highly male. So you see that actually more males have higher incidences of vascular dementia, and actually females have more higher incidence of Alzheimer's disease. So that's why we kind of have some differences in that as well. So again, there are different classifications of dementia. So we have reversible versus non-reversible, cortical, subcortical, and mixed types, primary or secondary, and progressive or not progressive. So some people can have a dementia where they have impairment in multiple cognitive domains, as well as functional impairment that also goes into giving the diagnosis, but it could not be progressive. So we have people who have, for instance, with the vascular dementia, it usually is progressive, but it's more progressive in a stepwise manner. So the patient has a stroke or a TIA, they go to a new functional level. They can stay there for a while until they have some other type of vascular incident or something else. Whereas usually Alzheimer's disease, we see a slow and steady decline. So there are differences in the ways that people change with the different disorders. And also you have secondary types of dementia. So you have Parkinson's dementia, for instance. So a patient who has Parkinson's disease, they then develop Parkinson's dementia as a result of the progression of that disease. We also still see that with AIDS, HIV and AIDS as well. You see different types of dementia that are actually associated with different disorders. And so these are the non-reversible dementias. Also note that alcohol-related dementias are in this. We, in the VA, have a large population of patients who have had alcohol and substance problems, and they do have, that does impact their cognition, and so we do a lot of times see some alcohol-related dementias as well. So one important note that assessment and evaluation is the key to intervention across care settings. So again, from that medical examination to the cognitive assessment, we need to know what's the baseline or what are we dealing with in order to get a very good diagnosis and then understand what we either need to expect or what's going on with the patient. And so that makes that a vital component of understanding each and every patient or resident, whether you're working in an inpatient facility or you're dealing with people outpatient. And I cannot say how important collateral sources are, and they're often vital to giving us more information as to how things work. You will not believe how much a wife can compensate for her husband in a way until you get him in a different setting and he is non-functional and you're kind of like, how are you all functioning at home? And she can tell you every single thing that she was doing for him. And so he wasn't really independent before he came in. He actually had declined significantly, but people have made accommodations for it. So again, you want to make sure you understand when you're dealing with what do we do next as far as treatment planning. So my big question, and we're getting to the behavioral part of things, is what is agitation? So lots of times when I get information on behavioral problems, I get a note that was written by a nurse or another provider, and it says that the veteran was very agitated, and so we did X, Y, and Z. Or we then gave him 1 milligram of Haldol. So what is agitation? Anybody can answer. I usually like going back and forth with the audience, but I know today we didn't get to do it as much. Anybody? Yelling and uncooperative. Is that it? Being aggressive. So yelling, uncooperative, aggressive, what else? Anger, frustration, pacing. Right. Anything else? Combative, confrontational. Okay, so when I see agitation on a chart, it tells me absolutely nothing about what actually happened. You tell somebody that a patient was agitated, and all we know is They could have had this whole realm. He could have been yelling, he could have been kicking, he could have been pacing, he could have been crumbling up a piece of paper, he could have been hitting, he could have been walking back and forth, he could have had repetitious language, he could have done one thing, it could have lasted all night. We don't know when people use agitation. So our first thing is we have to be able to describe what actually happens with the patient. In order to intervene with something, we have to know what it is we're treating. So we have to know what the behavior is that we're going to intervene for. So agitation is a term that's often used to describe behavioral symptoms that include verbal aggression, physical aggression, purposeless behaviors, or resistance to care. So again, you all gave a wide range of things, and they fit into all of these different categories. And so when we're trying to treat something, again, we don't just say, oh, a person is sick, and then expect to know what to do for this sick person. We start to identify their symptoms. And all in all, agitation is actually a symptom of a dementing disorder. What we're dealing with is we're dealing with what I like to think of. We think of organ failure, so we know what happens with liver failure. We know what happens with renal disease and renal failure. We know what symptoms come from that. What we're dealing with is brain failure. We're dealing with the fact that a patient's brain is no longer working appropriately. And so we're going to have to treat the said behaviors that are following through with that. And agitation or behavioral symptoms are just another problem that's stemming from these facts. So what are the symptoms? So all of these behaviors are thought to be symptoms of a disease or a disorder. So like I said, a dementia or even a reversible cause of dementia. So therefore, there is likely an underlying cause or trigger to the behavior. So that could be just the long-lasting progressive disorder itself, or it could be one of those other medical problems we talked about. It could be a UTI, it could be some other underlying infection. We don't always know exactly what it is. And so how do you assess and treat these things? So know what the likely causes are. So it's important to understand that behavior symptoms occur over the course of the disease process and often increase in the later stages. So again, we want to know where a person's baseline is so that we can know what is actually a change and what's not a change for them. So triggers can often be things such as even just a simple thing of difficulty with communicating. It's very frustrating if you can't communicate with someone and people's language, we talked about how people can have language issues. When people's language functioning declines, they aren't able to communicate things as well. They can't tell you they're in pain. They can't tell you that they just have something that itches. They can't tell you those things and express themselves in a way, so that can lead to some problematic behaviors. Environmental conditions. Is it cold in their room? Is it a new environment? I cannot tell you how moving a patient who has a cognitive issue, whether it be a dementia or something else, to a new environment, to a new setting, almost indelibly leads to some type of functional decline for that patient because they are not in the environment that they were used to and familiar and highly functioning in. So most often, you take a patient who is out in the community at home and you put them into a facility, you're going to see a decline. They may receive excellent care, better care than they had before, but they are in a different environment. So we just need to bring the expectation that we're going to see some type of change. You know, we are. But does that mean they're not as safe, if not safer, or they're not going to be overall healthier? No. But we just have to be aware that we likely will have a transition period. And then again, physical discomfort. So people just not able to tell you that their positioning is hurting or something else is bothering them. So one mnemonic that is used, this is by Gray, is it's used for, an observer-based approach to assessing behavior. So this mnemonic is one to help us to assess what the behaviors are. So I is for identity or identify. So what is the problem behavior? So again, we got this note that says agitation. We want to actually state what is the behavior. So what are they doing? So it's very important to use terms that are much more specific than agitation or the patient was difficult, so that the source of the problematic behaviors can be determined and correct interventions can be implemented. So again, what exactly? I is for identify what's going on. T is timing. So when does the behavior occur? What is the frequency of the behavior? So is it a one-time event? Did this just happen? Is this out of the blue? Did Mr. So-and-so do this? It's only happened this one time? Is it something that's happening weekly? Is it happening once a week? Is it happening early in the week? When is that happening? Is it happening daily? Does it happen in the morning or the afternoon, the evening, overnight, etc.? We want to make sure that we're being specific enough about the timing of these specific behaviors and how they occur. The S stands for surroundings. So where does this happen? Does this happen in the patient's room? Does it happen when we take them out of the room? Does it happen in bed, in their wheelchair? Where are we when this behavior happens? So that we can assess the environment. Is there something about this environment, the surroundings, that maybe would have triggered this behavior? Have there been recent environmental changes? So again, did they change rooms? Did they change settings? Have they been to the hospital recently and then come back? Is there overstimulation? Is there too much activity in the room? Are there too many things going on? Is there a temperature change or a temperature problem? So is it hot or cold in the room? And did that change recently? So again, the S stands for surroundings. O is others involved. So who else is involved? Is this happening when the nursing staff is trying to deal with the patient and provide some type of care for the patient? Is it happening when a family member comes and somebody else is visiting? Is it happening only with a wife? Is it happening with children? Is it happening with males? Is it happening with females? You'd be very surprised that that is actually very, very important, because you can even have veterans who have had things that have happened to them in the past, such as some type of trauma. So if we think of even like a sexual trauma or abuse that happened to them earlier in life, even as a child, some of the times those things rear their heads and they don't want a male caretaker, or a certain caretaker reminds them of a person who may have done that to them. So it's very important to understand what's going on and who's there. Is it a new staff person, an old staff person? What are we dealing with? V is very troubling. So how dangerous is it? Is what's going on with the patient going to harm them or your staff or their caregiver? Is somebody going to get hurt, or is it not so big of a deal? So we must address extreme behaviors immediately, while others should be observed over time so that we can truly assess what's going on with them. E is for evaluation. So what else might be causing the behavior? So again, this may mean if all of a sudden Mr. So-and-so is having this kind of exacerbation, all these behavior problems, or the same behavior problems but multiple times, maybe we need to go back to that evaluative process and do a physical exam or a cognitive status exam. Maybe we need to look for sensory deprivation. Are they having some hearing problems, or was there a change, cataracts, those types of things. Medications and other medical conditions. Maybe it's an exacerbation or example of some other type of problem that they have with other pre-existing condition that they have. Because behavior problems can often present as the first sign again of a more significant medical problem. And again, that's especially in our patients who are already demented. And R is recommendations. So how do I respond to this behavior? So after the previous questions are answered, and necessary evaluation or evaluations are performed, then therapeutic recommendations can be made and implemented. So as you can see, there's so many different things that you want to do before you even get to, well, what are we going to do about this? How do we respond to this behavior? And so that's where we come into kind of the idea of non-pharmacological interventions. So these should actually be the first line interventions for agitation and behavioral symptoms. And that's actually an expectation now. Why it's an expectation is because a lot of behaviors are not responsive to pharmacological interventions, and because it's actually going to be a mandate for most places now. Why? Because there is no FDA, for a lot of the behaviors associated with dementias, there is actually no FDA-approved medication that will actually treat them. And so we have to show that we have tried doing a lot of different things before we place somebody on a medication for these problematic behaviors. Medications are still very useful, but again, we want to make sure we've gone through these steps and shown that we've done our due diligence before we try them. So, Gray also has the 4S approach to actually doing these things. So S, number 1, is for safety. So control the risks. So we want to make sure we're controlling the physical risks, the financial risk. And so we're talking about driving. We're talking about, is this person safe to be at home? Can they manage their own finances? Are there any physical risks, such as fall risks? So we're trying to understand, how do we come up with something that's going to be helpful with this person? We make sure that, number 1, we move towards safety. The next is serenity. So managing affect. So avoiding overt frustration and anger. And I cannot tell you how this can go a very, very long way with patients, especially a lot of demented patients and some who are even further along. One of the things we know about demented patients is that a lot of time they mimic the affect of the people who are in the room, especially if they still maintain some of what we would call social comportment. You know, you've gone into the room where the patient kind of smiles and nods and just goes along with what you're saying. They may not understand what you're saying, but they're kind of looking at you and thinking, oh, okay, yeah, I'm gonna. So number 1, which I often tell a lot of nursing staff and other people who have to just go into a patient's room, is when you go into that room, make sure everything about you speaks a positive affect. Make sure you're smiling, your voice is calm, and everything, because you can actually scare someone who doesn't know who you are, who feels like they're in an unfamiliar place. But if they think, oh, this nice gentleman or this nice lady is coming in to help me, as opposed to just coming in and waking somebody up or doing something else or doing whatever you have to do, the affective change can make such a difference. When you go in with a smile and that smile in your voice or the calmness in your voice, a lot of times that in and of itself can set you up to have a much better interaction with someone. So again, it may sound like something simple, but that's hard when you've worked 8 hours of your 12-hour shift already and you're doing one thing after another. So we have to remain conscious of the fact that our affect and how we present ourselves to people really does make a major difference when we're dealing with these situations. Next is structure. Increase organization, maintain schedules, facilitates good habits. So one way to keep a patient, a demented patient, at home longer and at a higher functional level is to make sure that you implement some type of schedule so that the patient knows what's coming next. There aren't a whole lot of surprises. You keep that structure and the familiarity in the environment for patients, and they function higher. They don't have to remember what to do. It's almost automatic. Or things don't seem very different. They seem very familiar to them. Because now we're dealing with familiarity as opposed to somebody actually remembering what comes next. You want them to be comfortable because they're not going to necessarily remember what's going to come next. So one thing, again, to keep people at home is if somebody can organize and structure their environment, it goes a long way. And the next is sanity. And that goes to say for caregivers, making sure that all of our caregivers, from all of our staff if you're in a facility to all of our home caregivers, are taking care of themselves, that they're seeking the social support they need. Because again, when you're run down, when you're dealing with things over and over, when you're frustrated, that comes out in the care, and that is also sensed by the patient. Okay, so those things can help with what do we do as an actual intervention. And so the thing about coming up with these behavioral management plans is that there is no gold standard, this is the one thing you do. If you can tell, everything that we've talked about today has to do with an individual. It has to do with understanding where that individual is, understanding what's going on specifically with that individual patient. So unfortunately, there isn't just the one thing. It takes some trial and error, and it takes coming up with a behavioral management plan sometimes for them. So primary source for treatment teams and caregivers when addressing behavior. So we go back to these things that helps us specifically look at what's going on with that patient. Patient-specific document, like I said, to address their specific difficult behaviors and what methods we've tried to use to address them. Patient and resident preferences and indication for preventative actions. The best way to overcome a behavioral problem is to not do the things that precipitate the problem. So the best way to help our patients, residents, and those we're caring for at home is to know them. We need to know what types of things they like. We need to know what calms them down. We need to know what types of food they would like to eat, what time they would take a bath. If this patient was actually a patient who worked third shift his whole life, we need to understand that about him as far as what it's going to be like for his sleep-wake cycle. We need to understand our patients in order to prevent some of these actions. So overall, that makes prevention kind of the best intervention, but that means we have to know who we're dealing with. Here are a number of the different things that we can actually try with our patients. So again, understanding their abilities and limitations. When we push the envelope with somebody and ask them to do something that they can't do or have trouble doing, then we're asking them to get frustrated. So knowing what they can and cannot do. Redirection and distraction work well. Familiar objects, so again, making the room seem and feel home-like and familiar to someone. Soft, low speech. Calm, quiet environments. Short phrases and a slower rate. We cannot talk to our patients with cognitive problems and hold these long conversations and ask them all of these big questions. Slow it down. Slow your rate down. Slow the number of words you use. Shorten the sentences that you use, and give a long time for responses. Those types of things help with the communication, and they help with the patient not being overwhelmed by what you're saying. Reminiscence therapy. One thing we know, especially with Alzheimer's patients, is that things that happened in the past are the things that they may remember the most. Things like picture books that don't have a lot of words, but picture books from different time periods during their childhood, things like that, are things that can actually be very helpful when you're doing something like a reminiscence therapy with a patient who is actually demented. That way they don't have to talk and remember all of these things. You kind of open the book and take them back to those times themselves. It can be done with books that happen to deal with the environment they were in, or they can be family albums and people that they're familiar with. Other things, massage, aromatherapy, heat and temperature adjustments, light therapies, snooze-in therapy, which actually is a type of therapy that really incorporates some of these things, so kind of light therapy, temperature, aromatherapy, and actually different tactile and soft textures. Physical activity and wandering paths. So allowing a patient to actually wander in a safe environment is a very therapeutic thing to do. It allows them to, again, when we look at the 4 S's, and we talk about safety, as long as a patient is doing something that is not going to be harmful to them or to others, sometimes it's okay for them to do it. And sometimes we have to be okay with the fact that they are doing it. And so wandering paths are a way to allow people to safely walk. So important notes is that we must learn to overlook benign behaviors. We know that there are things that patients do that are outside of our social norms, that are things that we probably wouldn't do, but if they are not hurting the patient or anybody else, then sometimes we can just allow them to do them. Crumbling paper, doing repetitive actions, walking around, lots of times that's not going to cause the patient any problems, and so we need to just make sure we allow space for them to do those things without them harming themselves. Get to know your patient's likes and dislikes. Very important in that preventative aspect and in helping to assist somebody in getting away from the frustration and calming down. What do they like? What can be helpful? Work smarter and not harder. So don't keep pushing an activity or doing something over and over again with somebody who is obviously not following through and unable to do it. Come back later when they're more familiar with you, or try it again later. Don't keep pushing, because then you're going to get frustrated as well as others. So sometimes we have to learn how to do things in a way that's going to help us, as opposed to trying to force things in the normal scheme of things. Again, ignore benign behaviors and avoid personalizing hurtful or insensitive comments. Again, we're dealing with people who sometimes do not have a filter. We'll say things that can be very hurtful. We'll yell, we'll curse, we'll do a lot of these different behaviors, especially for caregivers at home. Cannot tell you how many people get their feelings hurt by the things that the patients are saying. They aren't aware of really what they're doing most of the time or how hurtful it is. So remembering that hurtful and insensitive comments or even hitting is actually not something that's personal is very important, again, for caregivers to understand when they're interacting with people. Realistic understanding that some problematic behaviors may not be eliminated. So going back again to the fact that these people are having problems that are causing their brain to not function properly means that we are going to have problems. They're going to have behavior problems. They are not going to be able to communicate with people properly. They are going to not have a filter. And so we may not be able to eliminate that, but that's where we have to adjust to the situation. And intervention is individual and takes trial and error. So again, not one thing works for every single person. And then some special things that we want to consider with veterans. We want to consider combat versus non-combat veterans, generation and null and error differences in our veteran population, injury service connection versus non-service connection, trauma, so PTSD and POWs. So our World War II Korean veterans, kind of that whole greatest generation and the silent generation, these veterans were thought of as heroes. They experienced this great economic growth and enhanced opportunities. These are participants in the civil rights movement. Socially, their families averaged one marriage. They were social drinkers. Also, smoking should be added to that. These were some of the things that were generationally appropriate. They're actually less likely to have a PTSD or trauma-related diagnosis. And note that I put diagnosis. That does not mean that they do not have PTSD or some type of trauma, which is very important because the traumas tend to rear their head again when we see them later in life and when we see them with dementing disorders. They tend to have an increase in flashbacks. They have an increase in memories of these very highly emotionally salient events. So we know that emotionally salient events are things that people still keep and recognize and know. They also have high rates of frostbite and depression. Again, kind of the silent generation, that stoic kind of look to them, and those types of things can all kind of build this picture of the type of man that you're dealing with. Again, though, everyone is an individual. Our Vietnam veterans are baby boomers. They returned amid strife and controversy. Many of them were mistreated. Many are suspicious of the system, so not only like our VA system, but they are any systematic rule, they are lots of times suspicious of that. Were raised during a period of great social change, have PTSD and trauma histories, and we also deal with Agent Orange exposure, which leads to a number of medical related diagnoses. So these are some of the things that we have to consider too when we're dealing with our population. What generationally have these populations had to deal with, and how does that affect how they react and how they interact with the world? Again, it's an individual thing, but we know that there's some cohort similarities in things that have happened to people. And to our veterans in these eras, we know that some of these things are still very salient. The mistreatment for a number of my veterans is still very, very real for them on a day-to-day basis. And you have to be understanding of that. So again, recent research has shown that dementia tends to exacerbate the PTSD symptoms. And also those with PTSD are at greater risk, so they're twice as likely to actually develop a dementia. So again, this is not something that's uncommon. It's actually very common to actually deal with patients who have these trauma histories. You're more likely to see the PTSD diagnosis on the chart of a Vietnam veteran, but you're not as likely to see it on the chart of a World War II or a Korean era veteran. And so it's still something that you want to consider. So no common triggers for PTSD symptoms. So again, TV shows or movies related to events, war or violence. A lot of times, even in our CLC, we'll have the news on. We have had how many mass shootings, how many things do we talk about, different sounds that deal with gunshots and this and that. Not necessarily the best thing to always have on television when you're dealing with PTSD. Baths and toileting can actually be an issue for patients. You'll see a lot of people who aren't wanting to take baths. You'll see a lot of people who have issues with toileting, especially if they're not able to do it for themselves. Again, the sex of the caregiver can be an issue. In the VA, we have rates of military sexual trauma. Our veterans have had and are victims of military sexual trauma, even though it's very much underreported in our male veterans and our female veterans. So again, we have to recognize those things, that people have had these situations and experiences with others that when they're vulnerable, they don't feel as though they can protect themselves from as well. Smells, so fires, certain foods, those things can also trigger PTSD symptoms. Sounds, so loud noises, certain songs, misinterpreted speech. Apparent threats are physical touch in sensitive areas, so we have to watch and listen to our veterans when they tell us certain things about how they like to be touched. Tucking in sheets and positioning. Had a World War II veteran who never wanted his feet tucked in, but he got to a palliative care, he got to a hospice unit. They kept tucking his feet in. He could not walk anymore, but he cursed just about every nurse out, and they didn't know why, and it was because his feet were tucked in. After that, his behavior changed drastically. So it can be something that is just so little that will change the level of care that somebody receives, their reaction to it, but we must understand those things about our patients. Again, medications can actually do that, and pain. Pain is, again, a large thing that can cause issues because a lot of times our veterans may not be able to really articulate what type of pain or discomfort they're in. So implications is that more comprehensive assessment is necessary for veterans with trauma histories. Traditional EBTs, so evidence-based therapies for PTSD, are effective for older veterans, but they are much less effective for veterans with cognitive impairment. So again, we can't send these veterans through trauma therapies at this point. So we want to just make sure that we're treating them and intervening in ways to decrease the stimulation and triggers that are in the environment and kind of enhance relaxation in the environment for them. So that is the end. So I don't know if anybody has any questions, but I have. We're just about out of time.
Great. Dr. Shead, you spoke about the Lewy body dementia. Can you just elaborate on that a little bit? And my second question is, you spoke about behavioral intervention. I work on a Alzheimer unit, so I deal with these patients, and I wanted to get your feedback on physical activity. One thing I like to do when my patients get restless and aggressive is walk my patients, and I'm trying to get some of the nursing staff more on board with doing that, so I just want to get your feelings on that as well.
Yeah, so I guess let's go to Lewy body dementia, and that Lewy body is a certain type of dementia, and so it's called Lewy body because of the Lewy bodies that are actually formed in the brain. It's really describing what's going on in the brain as far as what's going on in the disease process. So that's what, let me see if I have it on here. So again, it's just another type of dementia, and that actually describes what's actually going on in the brain. So with Alzheimer's disease, we see more of the plaques and tangles. And so it's really just the underlying pathology that's being talked about. And again, with a number of the different dementing processes, what you want to think of a dementia as is you really do want to think of it as a brain syndrome and a brain disorder and disease. So something is actually happening to the brain, whether it was an actual trauma or whether it's actually some other process that is working to cause the brain to not function or to actually atrophy in a lot of situations or to kind of be shut down. So even with vascular dementia, we're talking about the vascularity in the brain changing. So we're talking about so when we have, for instance, a stroke or TIAs and things like that, we're seeing vascular changes, and so that then leads to the brain not functioning as well. So that's kind of a very general overview of what I mean. But again, it's just the underlying process. Oh, and can I answer, do you have a question about that, or can I answer a second question? Okay. For the second part of your question about walking the patients and when they're restless, that exercise is actually very good for anybody, and it's actually excellent for older adults. A lot of times people are fearful of activity and exertion, and it is actually probably one of the leading reasons as to why we have so many behavior problems is because we don't actually get people up and active. So if you think about it, you've lived your whole life and you've gotten up to go to work and you go and you do some activity and then you go home and you're tired and you go to bed. Well, when we have our patients and they're kind of either just laying in bed, not doing a lot of activity, not really being interacted with or doing any physical involvement, we will then have many problems with their sleep-wake cycle, actually getting them to be tired at the appropriate times. They've taken a nap here, they've done this there. We're not actually getting them active enough. And for demented patients, many of them will, through even moderate to very close to the end until they're at the very end stages, that's when they lose a lot of their physical abilities, but up until a very large point, they are actually very, very active people. Some of them have kept the same physical, they physically are able to do so much more than they actually are able to understand cognitively. So I think it's an excellent idea to get patients walking or to do something. Again, that's why we have wandering paths. You want to get people up, you want to get them out and active. Music is one of the things. I mean, I think lots of people have probably now seen the YouTube video of the patient who listened to the iPod and then he was able to communicate even better. The stimulation is something that is actually very good.
Hello, can I interrupt?
Oh,
I was going to tell you, I used to work with Alzheimer's, and one of the things we did have a music program, but we also would have it so we had a couple females, but more males. So what we do, we get the nurses to dance with them. I mean, because that's part of, yeah. But I mean, you know, and you'd be surprised how much they enjoy it, and it's a good exercise for them. And we did it once a week, so.
yeah. But anything that engages, I mean, if you just think about it, we have to get them up and active if we want them to use that energy. They still have a lot of that energy, so we need to use it.
What is Snoozland therapy?
So Snoozland is a researched, and again, it actually has to do with a lot of different sensory, lots of sensory stimulation. So if you look up Snoozland therapy, you will actually get to a website that will describe a number of the different activities. But a lot of times they are now having either Snoozland carts or actually Snoozland therapy rooms in facilities. And they do it for children. There's not a whole lot of research to say that this is going to work, but they do this for children, for instance, who are autistic as well, and as well as people who have, as well as dementia patients. They're trying this therapy on them. And again, it's just another way to get to some type of stimulation that can be calming in a lot of ways. So one thing is that it'll have kind of that light therapy. So if you've ever seen like in the baby's rooms where you do the stars or have the different colored lights, it's very calming and it's a different sensory thing to actually get them engaged. Different types of textures, so things that are soft, things that are like teddy bears or things that you can rub on, blankets, silk, different things to kind of stimulate that sense. Aromatherapy is also often put in the room so that you have different smells. So again, it's really working on all of the sensory system for the patient. Again, there's some literature on it. There's not a whole lot. But there is not a whole lot of literature on behavioral management, and that is because it's such an individualized thing. But again, that is one type of therapy that is coming up, and I know the VA has actually implemented and placed Snoozland therapy rooms and carts in other facilities.